Well, I started out this morning talking about the ABCs of lung disease, and some of you I recognize and are now very familiar. And then I heard some of you went to hear Dr. Asasi's, our Doctor of the Year talk on pulmonary fibrosis. And so we're going to end the day with pulmonary hypertension for this group, but then I guess there's another lung talk in general right after this. So you're going to have lots of information about lung. So some of these slides are similar. And as lung disease is really a major cause of death. This is from the University of Pittsburgh when I was there, and the database that Dr. Thomas Metzger and I started. And this was all causes of death. And about half of patients die of non-scleroderma causes, just like everybody else, and cancer and heart disease and stuff. But of those that die of scleroderma, almost half of them die of some type of lung disease, pulmonary hypertension or pulmonary fibrosis, and a lot of times it's a combination of both. This is the sort of the picture of pulmonary arterial hypertension. The lungs are generally okay. They're clear. That's a chest x-ray, and black is good in that case because there's no scarring or anything there. And yet there is narrowing of the pulmonary arteries. Usually it's the smaller, the moderate-sized pulmonary arteries that get thickened. And when that happens, there's pressure buildup and you get enlargement of the right side of the heart. So this is the sort of the pathology, sort of simplified. Normal on top this is a blood vessel. And when you have cold exposure, everybody in the world get cold exposure, you get narrowing, you get spasm in the blood vessels. And that happens normally. When you have scleroderma, you have thickening of these blood vessels. And so when you get cold exposure and you get narrowing, you get really small blood vessels. And that's what happens in Raynaud's when you have trouble getting enough blood supply to your fingers. Well, that also happens in the lungs as well. So pulmonary hypertension is challenging to recognize both from your point of view, from the patient's point of view, as well as the doctor's point of view, because the symptoms are so nonspecific. Shortness of breath with exertion is one of the main symptoms, but that, as you know, is also a symptom of interstitial lung disease. Fatigue. Everybody has fatigue for various reasons, and that's a very common symptom of pulmonary hypertension. Chest pain, we don't get a lot of chest pain, but you can have chest pain. You can have cough, similar to interstitial lung disease, similar to reflux. Everybody gets a lot of cough with reflux, or even nasal sinus congestion, you can get cough. Rarely, and I've had a case, a patient where they fainted or near fainted. Swelling of the legs, that's a very common thing, as we've heard about in the news the last few days. And also then increased digital ulcers because of the low oxygen. It's not uncommon that I have a patient come in middle of summer, warm weather, and having lots more digital ulcers and having more troubles with Raynaud's because their oxygen is lower. So it is challenging. And that's what's one of the really important things is for you to try to recognize and gauge how much shortness of breath you're having. Again, it's shortness of breath, usually with activity. It's only really the very severe cases that they have shortness of breath just at rest. But it's really mostly problems with activity. And that you may not recognize you're having it, but it's really important to try to compare what you used to do last year or even 6 months ago or even a couple of weeks ago that you used to be able to climb the stairs carrying the laundry, but now you're asking somebody else to carry the laundry. Or you used to go to the grocery store all the time because you like going to the grocery store and doing things. Now you're too tired or you're just too short of breath. So when you see your doctor and you come to the office, you really need to be in tune with your body and just try to determine and help your doctor figure out whether you're going to have trouble with shortness of breath. Because they're going to ask you, are you short of breath? And your first response is, no, I'm fine. I'm doing okay. So really think about whether you can climb stairs as easily, carry bags, do things as fast or as frequently as you used to do. And make sure you keep that in mind when you go to see your doctor. So pulmonary hypertension, this is a Venn diagram We've been studying pulmonary hypertension for a long time in the connective tissue disease world. And there are lots of different kinds of pulmonary hypertension. And this was a Venn diagram by a cardiologist that developed it, but it really fits very well into connective tissue disease, particularly scleroderma, because all these types of pulmonary hypertension can happen in a scleroderma patient. So what we call group 1 pulmonary arterial hypertension is the sort of the classic one in scleroderma that we have all the different medications of. And this is the one that is specifically involving the pulmonary arteries in scleroderma. But the most common cause of pulmonary hypertension, which is not called pulmonary arterial hypertension, but just pulmonary hypertension, is from left heart involvement, particularly a weak left heart, somebody that's had a heart attack or something like that, or from aging to have stiffness in the heart, or from scleroderma to have stiffness in the heart. And that's got a bunch of names, HFrEF and pulmonary, I call it pulmonary venous hypertension because it's from the left side of the heart, or even diastolic dysfunction is another term for it that often is called pulmonary hypertension. It is pulmonary hypertension, but it's not the same kind of really very serious, deadly pulmonary hypertension that happens in scleroderma. There's also the kind of pulmonary hypertension that happens in patients that have lung fibrosis. So when you have lung fibrosis and you get scarring, you get low oxygen. And when you have low oxygen, that doesn't get enough oxygen to the heart. And so the heart doesn't function normally. And so then you can get pulmonary hypertension, which is more related to the severity of your lung disease and the fibrosis than rather to the primary problem in the arteries there. Another kind of lung disease, or pulmonary hypertension, which we don't see too much in scleroderma, but does happen in lupus, and that is the one associated with blood clots in the lung. This is group 4, chronic thromboembolic pulmonary hypertension. And again, this is not a real common manifestation, but I have a couple of patients that have developed pulmonary hypertension in scleroderma because of this complication. And then there's this other group, kind of off to the side. It doesn't even quite fit into the 1, 2, 3, 4 group, is involvement of the venules in the scleroderma patient, which there's an entity all by itself that's called whatever. But in scleroderma, venules are involved, which is unusual because the idiopathic type of pulmonary arterial hypertension doesn't usually have venule involvement. It's just the arterial. So as you can see, the diagnosis of pulmonary hypertension in a scleroderma can be any one of these. Group 1, pulmonary arterial hypertension. Group 2, or the pulmonary venous hypertension from the heart. Group 3, lung disease causing pulmonary hypertension. Group 4 is blood clots. And there's a group 5, which is sort of a wastebasket of other diagnoses that I don't think any of our patients fit into. So I just have told you all these things. Vascular, thickening of the pulmonary arteries, that's group 1. Heart involvement, stiffness, particularly the bottom of the heart or diastolic dysfunction, leads to pulmonary hypertension. 3, group 3, scarring or fibrosis because of the low oxygen, which stresses the heart and causes pulmonary hypertension. And so this is what we saw in the beginning of the talk. Right heart is large. You can't tell that, but that heart looks a little bit large. Maybe you would get used to it if you saw enough of it. And this is the same type of idea that I showed with Raynaud's. This is exactly what's happening in the pulmonary arteries. You have healthy pulmonary arteries. When you have increased blood flow, they can dilate and they can handle that pressure. But when you have scleroderma pulmonary arteries, which are thickened and stiff, when you have increased blood flow trying to go through those small little arteries, they can't expand, they can't dilate. So that builds up the pressure in the heart and makes it much harder for the heart to deal with it and to compensate. And so this is this complicated picture of how the blood flows in the heart. And this is the right side of the heart.
and this is the left side of the heart. The right side of the heart goes into the lungs, comes back, comes into the left side of the heart to get the oxygenated blood to go out to the rest of the body. And you can see this by these little arrows going, the green is the blood, gets its oxygen, and then comes back into the left side of the heart, goes out to the body, and then has more blood pressure in there, and then comes back in through the into the right atrium. And so that whole pathway is basically just to get oxygen into your blood from the lungs, into your heart, and around to the rest of your body. So when you have increased pressures here, that makes the right side of the heart dilate. It makes it weaker. It makes it just not work very well. And that's what when you end up with pulmonary arterial hypertension causing right heart failure. And that's all very cardiological. But we're going to really focus on the scleroderma aspects of this and how you and your doctors can help recognize whether you're at risk for particularly pulmonary arterial hypertension. And so these are some of the risk factors, and this is some based on some of the work I did early in my career. One of my first papers was a study, or Dr. Rodnan was, I don't know how many of you heard that name, but when I first started, Gerald Rodnan was sort of the king of scleroderma at the University of Pittsburgh, where I started out my career. And he was one of the first people with his cardiologist that identified pulmonary arterial hypertension in scleroderma. I mean, this is a while ago, but it's within my lifetime, so it's not that long ago. And so when I became a faculty and was studying scleroderma, we tried to identify patients that were at risk for pulmonary arterial hypertension. So we took patients that already had developed pulmonary hypertension, and then I looked back in their career and in their illness and tried to find different risk factors. So one thing we found is it tends to be older age people, later onset of disease. They often had long disease duration, as long as 10 or 15 years of Raynaud's. Sometimes they hadn't had the diagnosis made until they had the diagnosis of pulmonary hypertension. Limited cutaneous scleroderma, the anti-centromere antibody. These are terms that I used earlier in the talk, but this is the classic form of pulmonary arterial hypertension. African Americans and patients with an antibody that's called a nucleolar pattern ANA are also at increased risk. And so there's other people that have a little bit different disease, earlier disease, diffuse cutaneous disease, and another set of antibodies, and they're at risk. And then there have been other people that have shown that telangiectasias, those wonderful red spots that we all have in scleroderma patients, that's associated with age, longer disease duration that you have, also digital ulcer. So these are all things that can happen over time as you're developing pulmonary vascular disease in the pulmonary arteries that then lead to pulmonary hypertension. We talked about these autoantibodies, and as I said, the anti-centromere is the classic one. Topoisomerase, or SCL70, is the one that's associated with pulmonary fibrosis. And interestingly, this RNA polymerase III, which is the antibody that has some of the most severe diffuse cutaneous skin involvement, really has some lung involvement, but doesn't have a lot of severe fibrosis or pulmonary hypertension. So all three of those major antibodies have different types of lung involvement. And then these other antibodies, which are less common, but some of them are those nucleolar antibodies that I was mentioning, are also associated particularly with pulmonary arterial hypertension. But one of the important risk factors that we talked about, along with shortness of breath, are these tests that we do, pulmonary function tests and echocardiogram. And one of my studies really showed that that the DLCO, the diffusing capacity for carbon monoxide, which is one of those tests on the pulmonary function tests, or PFTs, that's a really good predictive factor. It doesn't say you're going to absolutely get pulmonary hypertension, But if you have a normal DLCO and you've had the disease for 10 years, the likelihood of you getting pulmonary arterial hypertension really is pretty small, as opposed to if you have a DLCO that's less than 60%. That's a clue that you could, not everybody does, but you could be at risk for getting pulmonary arterial hypertension. And then this ratio, this FVC. So the FVC is one of the parameters that we look at for people that have pulmonary fibrosis. And so if that's normal or pretty close to normal, you're not likely to have severe pulmonary fibrosis. But if you have a very low DLCO, that ratio of the forced vital capacity over the DLCO is quite high. And that's turned out to be a very reliable risk factor. Again, it's not a diagnostic, it's not a screening, it's a risk factor. And even though I identified this years ago, before rheumatologists were very good at reading PFTs, there was a time we didn't even hardly know how to read PFTs because we didn't have any treatments, we didn't know what to do with these things. And so I established this so that rheumatologists could understand that this was not associated with severe fibrosis. It was associated with the low DLCO. So we talked about the pulmonary function tests, and these, hopefully, all the patients here have already had PFTs. And again, this is the two major tests that we measure, the forced vital capacity, or the FVC, and that's really how much air you can get in. And if you have fibrosis and you have scarring in your lungs, you can't get as much air, and so that lowers the forced vital capacity. Whereas the diffusing capacity, which is measuring the oxygen diffusing from the lung, from the air cells in the lung, into the little arteries in the bloodstream, into the to carry the in the blood into the heart and to the rest of the body. And so when that is decreased, it can be either from decreased because you have fibrosis in there or because the blood vessels are thickened. So there's two ways that DLCO can be decreased. And so this was one of the results of one of the studies that I did. So when we looked at patients who had the diagnosis of pulmonary arterial hypertension, and we looked at what their DLCO was long before they ever had evidence of pulmonary arterial hypertension, in this group of patients that had PAH, their DLCO was 52% predicted. That's lower than 60%. And that was there for many years before they developed pulmonary arterial hypertension. Whereas the control scleroderma patients who didn't ever get pulmonary hypertension, they had a normal one, greater than 80% is normal. And this was in the PAH patients, this was almost 5 years before they were diagnosed with pulmonary hypertension. In the controls, it was about the same, it was 6 years. And then this was the group of patients, this was about 20 patients who each had pulmonary function tests in the 5-year time periods of each of these things, up to 15 years before they were diagnosed with PAH. And they started out with a normal DLCO, and then over time, it decreased. And then somewhere in this 5 years before they developed pulmonary arterial hypertension, that's then one of the clues that their doctor should be looking very closely and monitoring the echocardiogram at that time, because that's when we can make these diagnoses earlier than waiting for you to get severe symptoms. The control group just stayed stable at 80%. So this has really turned out to be, I think, for rheumatologists, a very helpful clue to try to understand whether you're at risk.
Does this hold true, meaning the DLCO, does it also possibly predict type 3?
Type 3. So interestingly, you asked that. The DLCO, oftentimes in somebody that has pulmonary fibrosis, and quite severe pulmonary fibrosis, it's stable. People get hypoxic, they're on oxygen. And then right before they get pulmonary hypertension, that DLCO does decrease lower. And some of the lowest DLCOs that we see are in patients that have also have pulmonary fibrosis. That's not quite as clear because there are so many things when somebody has fibrosis that DLCO can be lower because the fibrosis is worse. So it's a little hard to prove, but it does happen. And this was from another study. We had a study, 20 sites across the US. Many of the doctors that are here today giving talks were part of this study. It was called PHAROS. And in this registry, we ended up with 450 patients. 250 of them had newly diagnosed pulmonary arterial hypertension. Another group had group 2, another group had group 3, and then we had this other group that was just at risk for having pulmonary hypertension. And we showed who then developed pulmonary hypertension. But this was at the time of the diagnosis of pulmonary hypertension, and this is the mean pulmonary artery pressure, but all these people had pulmonary hypertension. And look at the DLCO. There's only a couple of people that had normal DLCOs, and this was at the time of the diagnosis. So having a normal DLCO and greater than 80% is really is not a risk factor, and you're really not at high risk at that point. So the echocardiogram, this is that sound wave test that you have that the doctors do. This is really the screening test for pulmonary arterial hypertension. So once you have a low DLCO, you're in that high risk group, this is the time that you need to have echoes every year, even if you don't have any symptoms at all. And it's really important because these are subtle findings on the echo, and you may not have gotten significant shortness of breath. But that's okay because we have lots of treatments, and we want to identify patients that have pulmonary arterial hypertension before they get really sick because we have so many different things to treat them with now. And so the problems with the echo is that even though it's a great screening tool, it's not always easy to read. Sometimes the pulmonary artery pressure can't even be determined. So what they do is when they're measuring the pulmonary artery pressures, they're measuring the wave between one of the valves, and they have to, they're talking about a pressure wave like this, and it's a very small number, and they measure it, and then they have to do a formula to get the actual mean pulmonary artery pressure. So there's lots of ways that if you don't measure it quite right, that number's going to be off. So there's really a range where the value of the echo pulmonary artery pressure is not that accurate, and that's why we have to confirm it on a right heart catheterization. So false values are actually quite common, and as we talked about, there's lots of causes of elevated pulmonary pressures. It's not just PAH, but it can be left heart disease, it can be pulmonary fibrosis, it can be from blood clots, and there's lots of issues that we need to sort out. And you never should take treatment for pulmonary arterial hypertension until you've had a right heart cath. That's really the gold standard, and it really needs to be done by a reputable heart catheterization person, but there are plenty of those around, thankfully. And this is, again, the right heart cath is an invasive procedure, but it really isn't quite as bad as many invasive procedures. It is a catheter that they go into the artery and then measure the pressures in the heart, but they're not using any dye. It's just flow, and they're not catheterizing the coronary arteries or doing anything to the, to the small vessels. It's just measuring pressures. And so all the guidelines, we've been looking at this for a long time now because we've had drugs now for pulmonary hypertension for 25 years. So that's really exciting. And so these are some of the guidelines for screening and detection of pulmonary artery hypertension. All patients should be screened for PAH yearly. Now that doesn't mean all patients have to have echoes every year, but you have to see your doctor. And this is patients. And I can't tell you, I've diagnosed patients 10 years ago. They go back to their primary care doctor. Doctor doesn't pay any attention to what I told them to do. And they come back to me 10 years later. But you didn't tell me. And I said, yes, I did. And so I don't want that to happen to you, because you're all going to know about this, and you don't want to wait until you already have severe disease. Patients that have screening, it may just mean that your doctor talks to you. It may mean that you get PFTs. It may mean that you get echocardiogram. So all of this is really important. And once your doctor thinks that you have potential of having PAH, then you have to be referred to have the right heart cath, which is, as I say, mandatory for the diagnosis of PAH. So lots of difficulty with testing. We've already heard about the echocardiograms. Blood tests are sometimes hard to get because it's hard to get blood from scleroderma patients. Also, sometimes you can get abnormal liver function tests, and I think Dr. Freck probably talked to you about some of the blood tests that are involved in scleroderma patients. But they can mimic, when you have abnormal liver tests, they can be mimicked because you have elevated muscle enzyme tests, and those overlap a lot. We had a patient this week who'd been diagnosed with some sort of liver disease because she had all these abnormal liver disease. In reality, she had muscle disease. She had inflammation in her muscles. Pulmonary function tests are hard to do. As you know, you have small mouths, and some of the community pulmonary labs don't have nice flexible mouthpieces, and it's really hard to do. Echoes and cath, you have to lay down flat, but reflux interferes with that. And then another test is a 6-minute walk test, which is a common test to show your response to exercise. And what they do is make you walk up and down a hall, and they measure your oxygen. Well, where do they put the oxygen? On your fingers, which when you walk, what happens to the blood flow in your fingers? It's going to all the muscles in your body. You have Raynaud's, and you can't get a measurement. And I can't tell you, I've had more than a few patients get put on oxygen because their doctor didn't even realize that the reason they had low oxygen on their oxygen saturation was because of Raynaud's. Amazing that they do that. So we use, many reputable pulmonary labs use what we call a forehead probe, which doesn't interfere with walking, and you just carry this thing and you can measure the oxygen saturation much more realistically than you can on a finger. Other things that interfere with doing the 6-minute walk is just age, having arthritis, I got called once by a pulmonologist saying, "Oh, I just got the 6-minute walk on Mrs. X, and she's dropped her walk distance by about 100 meters." And I said, "Well, she happens to be in my office, and she has an Una boot on because she sprained her ankle." And they said, "Oh, I understand now." So there's lots of things that interfere with the 6-minute walk, but most importantly, you really need to have a forehead probe, or sometimes an ear probe can be accurate in some patients, but not everybody have great earlobes. So one of the most exciting things that has happened during my career in scleroderma is the treatment for pulmonary arterial hypertension. So I've been at Georgetown now for about 25 years, and that was about the time that the first medication was first approved for pulmonary arterial hypertension. And that was really a very exciting time because, as I said, we never had any treatment. Nothing could be done for pulmonary hypertension. And now we have all kinds of treatments. There are 3 major pathways, and these are all kind of complicated pathways. One of the pathways is called endothelin, and this chemical is one of the strongest vasoconstrictors. It constricts blood vessels very strongly, and so we now have 3 drugs that block that pathway. And so those are the 3. They're all oral medications. There's another pathway called nitric oxide. Nitric oxide is a chemical that dilates blood vessels. And so that's a really important pathway to try to get increased dilation of the blood vessels, in particular the pulmonary arteries. And there's several of those, tadalafil and sildenafil. This is one family, and there's another family called soluble guanylate cyclase stimulator, mouthfuls. But all of those are trying to dilate the blood vessels. And then the third one, the most potent dilator, are prostacyclins. And these are the most potent medications we have. And they come in all forms. So we have some oral ones. Selexipag is an oral one, as well as Orenitram, which is a treprostinil oral. But they also come in inhaled ones and intravenous ones and subcutaneous. So there's all kinds of things. And this is the triple therapy. And most commonly, we start out with one or two of these, usually dual therapy. There was one study that showed that a combination of ambrisentan and tadalafil, two of these pathways, was better than one drug in either pathway. And so really ever since that study, that's been sort of the standard of care. And then if that isn't good enough, then they add a prostacyclin. This is all being done mostly now by pulmonary hypertension specialists. This is a very complicated course of treatment, and it's not easy to get approved, as you might imagine. So I think almost it really should be handled by doctors who really deal with this all the time. So the exciting thing, even more exciting, is that there is a new pathway. This is a new pathway that's drug has only been out for probably a year. This is a very complicated drug. It's a fusion protein at blah, 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 blah. But anyway, it's the TGF-beta superfamily. TGF-beta is one of the, if you're into the basic sciences, this is one of the cytokines that really is a very strong player in scleroderma and in blood vessels and in fibrosis. And so this drug has a pathway so that it blocks it. And when they did the study, it was in patients with PAH. All the studies in PAH are always done allowing scleroderma and other autoimmune diseases with pulmonary arterial hypertension, PAH, not related to other things, but with PAH, into the study. And usually there's about 25 to 30% that are in this connective tissue disease pathway. It was a little lower in this study, only about 15%. But when the drug then goes to approval, it's then approved for all of the diseases, which has really been great for ours. And so this was studied in patients that already had significant pulmonary arterial hypertension with 2 or 3 drugs as background therapy. And so what they did is measure the 6-minute walk distance. We talked about this 6-minute walk and oxygen saturation, but one of the outcome measures in pulmonary arterial hypertension is how far the patient walks. There are other ones, but that's one of them. But remember, these patients were on 2 or 3 background drugs already for their pulmonary arterial hypertension. And in this picture, as I can see, this is the placebo. So this is over a 6-month time period. So again, they didn't know whether they were on placebo or drug. And so the patients that on placebo did not have any improvement in their 6-minute walk. And yet the patients on sotatercept had significant. It doesn't look like it's significant, but that really, considering they're on 2 or 3 other drugs for their pulmonary hypertension, really was a meaningful improvement. They also looked at survival, and their definition of survival is not just death, but it's worsening of their disease, requiring different procedures or additional drugs or something, hospitalization. And as you can see, again, the yellow line is the sotatercept over that 6-month period compared to the placebo. So this was now approved and is in use. I have 1 patient in it. So the sort of the challenging thing with this drug is that one of the side effects of it is that it develops telangiectasias. I'm not sure that this is going to be a great drug, but the studies didn't show that the people that developed telangiectasias were worrisome types of telangiectasias. I worry that there are telangiectasias in the GI tract that can bleed. We don't know, but I know the patient of mine that's on this we're monitoring things very closely, watching the blood count very closely. But it really is a very exciting potential new pathway, and we're hopeful that this is going to lead. There's still more drugs that they're trying. So again, this hasn't been a cure, but it certainly is an exciting time to have long-term better outcomes. Why is it so hard to treat? One, we had to find drugs that worked, which fortunately we had, but patients tend to be older. I told you that the risk factor was somebody that's had disease a long time, had the onset of their disease as an older person possibly. And then we have confounding problems with interstitial lung disease. We have left heart disease with diastolic problems. We have right heart disease. So one of my very close colleagues at Hopkins, Dr. Paul Hussein, said, he thinks that there's a primary problem in scleroderma in the right heart, in addition to the pulmonary arteries. So there's complications there. The pulmonary arteries in scleroderma compared to the pulmonary arteries in idiopathic pulmonary arterial hypertension are more socked in. And so part of the reason is that the layers of the blood vessels around the outside of the blood vessel are more involved in scleroderma. The internal part is similar to it is in other diseases with pulmonary arterial hypertension, but in scleroderma, that adventitia, which is around the outside of the blood vessel, has more fibrosis there. Confounding musculoskeletal problems, deconditioning, and then the bigger problem is still, as much as we've been trying to educate our primary care doctors, our primary rheumatologists, even more so our primary cardiologists and pulmonologists, what it is in a scleroderma patient that is so important to look for and to identify, because we still have people coming late. And as I said, I have at least several a year where patients that, as I say, I can show them the letter that I sent to their primary doctor to get PFTs, to get echoes, and not just wait until the patient shows up with very severe shortness of breath and severe oxygenation. So we haven't succeeded yet, but we keep trying, and we're getting there. So the treatment problems, hard to know which aspect of the disease is getting worse. We talked about fibrosis and vascular disease. Those are confusing. When you have abnormal liver function tests, LFTs, another ABC, you don't know whether this is from toxicity from the drug or whether it's you're having muscle disease or whether it's something else. And then if you have bleeding and you develop anemia and you get bleeding from the esophagus or the stomach, is it from scleroderma? Some patients are on anticoagulation. Some patients now on sotatercept may have bleeding from telangiectasias. So we've talked about a lot of these problems in addition to pulmonary arterial hypertension. Lots of things going on. We really don't have time probably to talk about all of those things. So management suggestions. It's really, again, I can't emphasize how important it is to be attentive to your symptoms, to work very closely with both your rheumatologist as well as your pulmonary hypertension doctor. And sometimes that's a cardiologist and sometimes that's a pulmonologist. It just depends on the community that you're in. And then you need to work together because I can guarantee you the pulmonary and cardiologists are not going to want to deal with your Raynaud's and your ulcerations and your calcinosis and your esophageal and your small bowel and all that we have to deal with, which is fine. But there's lots of things happening, and it's such an exciting time to have early diagnosis and treatment, which can really make a difference. This is from our Pharos registry. So this was, as I said, it's about a 15-year study. was the final paper that came out in 2018. And this was from the Pittsburgh database before there was any treatment. This is survival here, overall survival. So as you can see, before there was any treatment, literally everybody died from it. This is when the REVEAL registry is from the pulmonary world. So if you come to the pulmonary hypertension groups and you get diagnosed with scleroderma and pulmonary arterial hypertension, at that point you had a 5-year survival of 40%. So in our Pharaoh study, overall, you had a 5-year survival of 76%. That's really very good considering, as I say, 15 years ago, almost everybody died from it. And then all-cause mortality, because you get cancer, or you have heart disease, or you get infections, you have other things that happen. Not all scleroderma patients with pulmonary arterial hypertension die of pulmonary hypertension, die of other things. So that's really made a lot of progress in the 25 years. These are just some of the things, the other kinds of pulmonary hypertension. This is the type from heart disease, and again, older women, diffuse scleroderma with kidney problems, patients with a nucleolar antibody, but you can have it from any kind of heart disease. It's really, diastolic dysfunction is really kind of a common older age population problem, and this is very hard to separate whether it's from just having stiff heart or whether it's from scleroderma. And as we talked about, the pulmonary hypertension from lung fibrosis, which is more severe in diffuse scleroderma, men, African American, and those with anti-SCL70. But the lung scarring occurs early in the disease, and then the pulmonary fibrosis gets worse, and then you get low oxygen, and then you get pulmonary hypertension. And this type of PH has not been responsive to other PAH types of drugs. And a lot of people have had secondary complications when they get those drugs if they have pulmonary fibrosis. And so that is a big problem. But now we have a treatment for what we call group 3 PH-ILD. And most patients that had this type of pulmonary hypertension had failed treatment with all of our other drugs because of the hypoxia. And that's the low oxygen. But we now have a drug. This is called treprostinil inhaled. And this was another large study that measured the 6-minute walk distance. And I think that's here. And these were patients that had severe fibrosis, had pulmonary hypertension, and we didn't have any treatment for them. So we gave them this inhaled blood prostacyclin. So it dilated the the pulmonary arteries from breathing it inside. And as you can see, those on inhaled treprostinil had improvement in their 6-minute walk compared to the placebo. So that really has made another new exciting treatment available for patients with a different type of pulmonary hypertension. So what does this mean for you? All patients need to know what their PFTs are, what their DLCO is, what the ratio is, and if they're at high risk, they have PFTs and echo every year, they get their right heart catheterization, and if they get that diagnosis, they get treated and they hopefully have stabilization. They have complications, and sometimes it's really challenging even with all these medications, but at least we have lots of opportunities for treatment. So in summary, lung disease is the most serious complication in scleroderma. All patients should be screened somehow or another for pulmonary hypertension. You must pay attention to your breathing. There's lots of treatments, but we really need the help of our pulmonary and cardiology colleagues. And the key thing is to identify it early, treat it aggressively, because we have made PAH a treatable part of scleroderma, which was not the case before. So, questions?
Are any of the PAH drugs that you mentioned, including the new one or the group 3 new drug, not indicated or work when the patient has renal failure or anemia?
Certainly renal failure and dialysis makes it challenging. We do use most of them. I think the bigger trouble is the liver disease, because these all, some of the oral drugs have liver problems. Most of them aren't cleared by the kidneys, so usually that isn't as much of a problem as it is if you have liver disease. I know I have a couple of patients that have some sort of other liver disease, not scleroderma related, and they have really limited. The inhaled drug is not a problem, so we use that frequently.
But that would really just be for group 3 rather than the general.
So the inhaled drug is also approved for group 1.
Oh, okay.
Yeah.
Does the, and I'm going to use the easier name, Tyvaso, for group 3. I understand that it has increased patients' 6-minute walk test. Has it also increased longevity?
So that it's hard to say longevity, but they use what's called a composite endpoint because they have reasons. It's not just death. We can't carry these studies long enough for people to die, but it's hospitalizations because of heart failure, or you have to add another drug, or there's a composite. Each study, unfortunately, uses a slightly different composite, but yes, they have shown not only the 6-minute walk distance improvement, but improvement in time to worsening is whatever their composite endpoint is. Yeah, no, it's really been very exciting, but it's very challenging. These are very complicated, sick patients, and as I say, I started out in this field when it was 1 drug and 2 drugs, and it was not very complicated, and my nurse could get the drug approved. I mean, now it's very, very. You need a full-time nurse and a pharmacy person really working with you to deal with all these drugs, because there's so many. I mean, they're not just those drugs, because you have to have drugs for fluid retention and all the heart failure things that go along with that. So it isn't.
Is that for type 1? Because I'm type 3, and I just have.
Right. So it just depends on the severity of it. Yeah.
I have a question. You mentioned Dr. Frick earlier. I used to go to her when I was in Utah. I've moved here to St. Louis, and part of her protocol for scleroderma patients was heart catheters every year. Now, in 5 years, I've only had 1. What is the recommendation for that, or is there?
So it's really up to the pulmonary hypertension doctor. And having worked with multiple people, so I'm in DC, and I have my own person. I have somebody across the river here. I have somebody across the river here. Somebody at Hopkins. So I have a bunch of different people, and they all do it differently. I mean, some have a very routine, and I also have patients that live elsewhere and still come back to me because they've moved. And some do it every year. Some people just do it if there's signs that things are getting worse, or if they want to change a medication. They want to see whether it's still pulmonary arterial hypertension, whether you now have had complications related to the left heart, because that's a common difficulty in trying to sort out. You may have started out with PAH, but now 5 years later, you're older, and now you may have some stiffness in the heart, and maybe that's left heart disease. So it is a very challenging problem, but it is also a very individual problem with each, not problem, approach to it by each pulmonary hypertension person. There isn't any one way of doing it.
I have one more question.
Sure.
Okay, so pulmonary arterial hypertension, your veins are smaller.
Your arteries.
Medications are supposed to
Dilate them.
open up the veins.
Arteries.
To
Arteries.
to increase the blood flow.
Right.
But my problem is, and I guess I've never really asked my doctor, but I'm constantly 95% of the time, I'm 96/60. It's low.
So that's part of the challenge, is because you're dilating arteries in somebody that has a low blood pressure, and we don't always succeed in doing it. Yeah. No, that's. Most of our scleroderma patients don't start out with high blood pressure. They start out with normal blood pressure, and when the heart doesn't work very well, it doesn't have enough pump in it, so that it makes it difficulty. It makes it very challenging to give some of these medications when your blood pressure's low like that. Yep.
With that, I get the fatigue.
Sure. Yeah.
So.
Yeah, no, this is not an easy thing. I mean, the Pulmonary Hypertension Association has meetings just like we have with scleroderma, where they have 2 days of just discussion on how you deal with pulmonary arterial hypertension. I mean, it's an entity all by itself.
When you were talking about the screening can be kind of different things, I was wondering whether antibodies influence whether or not, for instance, you would have the right heart echo versus a different type of assessment?
So the antibodies are helpful again, they're a risk factor. They're just one of the measures that we look at a patient to see whether they're at high risk or low risk. They're not a be-all and end-all. They're just one measure to help us decide whether you're at high risk. Again, it wouldn't have anything to do with the diagnosis. It's only for helping. So when I get referred a patient and the patient doesn't have any risk factors and the echo looks fine and they've had this diagnosis of pulmonary hypertension, wait a minute here. So, I mean, that happens all the time, because remember, the most common type of pulmonary hypertension in the community is left heart disease. And so the cardiologist will do an echo and say, oh, you have some pulmonary hypertension. Tell the rheumatologist says, oh, that's pulmonary hypertension from scleroderma. Maybe it's not. And so then the rheumatologist, again, with the cardiologist or the pulmonary hypertension person, has to sort out which kind of pulmonary hypertension this is. And it's not always easy. It's not straightforward. And many scleroderma patients, that Venn diagram I showed you, many of my patients have some of all 3 kinds of pulmonary hypertension. They have some left heart disease, they have some interstitial lung disease, and I really think they still have some primary pulmonary vascular disease. So it really is a very complicated process. Any other questions? One more?
Yes, one more. In 2019, I was formally diagnosed, even though I think I had symptoms years before. Then in 2019, I started having problems with pushing my sister in the wheelchair, really short of breath. And I went to the hospital, and it was like the floor dropped off. I was diagnosed with the Raynaud's, scleroderma, cardiomyopathy, and PH.
Yeah.
And so I'm wondering, was my cardiomyopathy?
So that's right. That's a very challenging group of patients, because the cardiomyopathy can cause PH. That's the left heart disease. And so left heart disease can either be from cardiomyopathy, where the heart doesn't function, doesn't pump well, the ejection fraction's low, or because it's stiff, or many other reasons. But that cardiomyopathy can happen in scleroderma as well. So again, there's a combination of those things. And again, that's why it takes all these people to try to sort it out. But sometimes the cardiomyopathy is the primary problem. And unfortunately, we don't have specific treatments for the cardiomyopathy. I mean, the cardiologists have all kinds of drugs, because that's such a common problem that they have I mean, I don't even know all the different drugs that they do, but they have lots of different, very specific drugs to improve the pumping of the heart, independent of the pulmonary arterial hypertension. So ends up with lots of medications.
Fortunately, I'm only on the tadalafil and the ambrisentan right now, along with my blood pressure pill.
Yeah. Well, thank you very much, and I'm glad to see so many people that are doing well with pulmonary hypertension too, hopefully.